Hi, my name is Jasmine Kidd, and the title of my Doctor of Nursing scholarly project is Addressing Pain Management in Cesarean Deliveries Using Tylenol and Motrin. My amazing committee is as follows: my DNP chair, Dr. Jessica Bland, the director of Doctor of Nursing Practice Programs, Dr. Maria Snell, and my community leader, Dr. Madeline Lovenow. So, what is the background or significance of this project? Cesarean sections, also known as C-sections, are the most prevalent type of delivery procedure in the United States, with a comparative rate of 31.8% versus vaginal births. So these are statistics from 2022. I currently live in Illinois, and I wanted to provide the statistics for cesarean deliveries where I currently reside. So, per the CDC, in 2021, Illinois represented 31.2% of all live births that were cesarean deliveries. Now, this might not sound like a lot, but unfortunately, C-sections have become more common compared to vaginal deliveries, which puts moms at risk for several complications, including bleeding, infection, and poorly managed pain. And sometimes, if it's not a scheduled C-sections, sometimes people have C-sections because it's an emergency or a crash C-section and they have to. So not all C-sections are planned. Sometimes they have to have them to save the mother and the baby's life. So, regarding pain, patients' post cesarean experience is distinct and complex. Thus, providing patients with the appropriate analgesics is crucial. So, following a cesarean birth, effective postoperative pain management is crucial for patient recovery. So, utilizing a multimodal analgesia approach, which combines scheduled Tylenol, non-steroidal anti-inflammatory drugs, also known as NSAIDs, and opioids as needed, is recommended to alleviate discomfort. So we have to prioritize first-line analgesics like Tylenol and Motrin alongside NSAIDs, which can significantly reduce the demand for opioids by up to 50%, which is amazing. This is crucial. This is definitely significant to better pain management. So, the early recovery after surgery, also known as the ERAS program, which interchangeably is also called the Enhanced Recovery After Surgery Protocol, was established in 1997 and aims to optimize surgical outcomes, including those of cesarean deliveries. So, statistics indicate a concerning trend in this opioid consumption with the opioid crisis. So, with Americans accounting for a significant portion globally, we are trying to use the opioids but remain appropriate in cases of inadequate pain, and we must exalt those non opioids first. So, care providers should exhaust non-opioid options first to mitigate the risk of that opioid dependence post-cesarean. So, the implementation of the ERAS protocol can significantly reduce opioid exposure and alleviate high-level pain scores following cesarean sections, which leads to improved patient outcomes and dispelling misconceptions surrounding that opioid-centric pain management practices. So the ERAS protocols was spearheaded by a team of general surgeons, and the ERAS emphasizes evidence-based strategies, which we love, such as this multimodal therapy to enhance preoperative, intraoperative, and postoperative care. But for the basis of my DNP scholarly project, I will be focusing on the postoperative care or the postpartum care. Review of the literature. So I reviewed 20 articles for my literature review, and amongst those articles, I established 5 themes. Those 5 things are as follows: primary analgesics, Tylenol and Motrin, as needed opioids, standardized protocol regimen, under treatment of pain, and effects of breastfeeding and bonding with their newborn. Theoretical framework. So this GMP project is thus framed with a theory-based intervention approach as articulated by Pollitt and Beck, which emphasizes the explicit theoretical model guiding interventions in their outcomes. So implementing the early recovery after surgery approach and advocating for scheduled Tylenol and Motrin alongside as-needed opioids is crucial for enhancing patient outcomes and generating an impactful healthcare data. So the relevance of the Donald Beaton model is analyzing health services and assessing quality remains significant with a focus on structure, process, and outcome components. So for the structure component, this is the physical and organizational characteristics where healthcare occurs. So this is the hospital, the clinic, where we are trying to implement the protocol. The process. The process focuses on the care delivered to the patients, for example, the service, the diagnostics, or the treatment. For this case, the treatment is a scheduled regimen of Tylenol and Motrin and as-needed opioids. And the outcome. The outcome is the effects of healthcare on the status of the patients and the populations. So the patients is the improved pain scores and the population is the cesarean sections. So by integrating these theoretical frameworks, the aim is to improve pain management and cesarean deliveries, which is poised to positively impact patient outcomes and overall healthcare quality. So the dynamic worldwide drive for high quality healthcare presently makes Donald Beaton's work still relevant. Thus, efforts to evaluate and improve quality continue to center on the organizational principles of structure, process, and outcome. So the structure includes these elements that influence the environment in which care is provided, such as safe, like staff training or services, or proper steps for pain management. And then those other categories of processes include technical processes, which describe how care is provided, and interpersonal processes, which cover all aspects of care delivery. So finally, the outcome includes all healthcare impacts on individuals or populations, including alterations to health status and patient satisfaction and quality of life about one's health. So enhancing pain management and cesarean deliveries using these theoretical frameworks should improve patient outcomes. So my method and design comprised of a retrospective chart review of 80 postpartum cesarean sections, and I identified pain scores at 24 hours. And if you want to know why I use pain scores at 24 hours, it's because we know that the first 24 hours post any kind of surgery, but in this case, cesarean sections, is crucial. We want to make sure patients' pain is adequately controlled so that they do not have that breakthrough pain. And breakthrough pain is this intense pain that just comes out of nowhere. It is really hard to manage if you're not on a scheduled regimen or some form of scheduled regimen. So if you have that breakthrough pain, unfortunately, you might have to use that opioid or you might have to use that narcotic. So our goal is to prevent that so we do not have to go that route. So I determined which patients receive the minimum doses of Tylenol and Motrin, and which patients receive maximum dosages of Tylenol and Motrin. So I also wanted to point out within 24 hours, patients are getting scheduled Tylenol and Motrin together every 6 hours. Every 6 hours, they're getting this medication. Tylenol per tablet is 650 milligrams. In a maximum of 24 hours, they can get 2,600 milligrams of Tylenol. And Motrin is 600 milligrams. And also, they get that every 6 hours. The maximum dosage per tab is 600 milligrams. Maximum dosage in 24 hours is 2,400. So they get these together. They're not off schedule. They have to get them together because we know that Tylenol and Motrin, they work great. They're great individually, but if we put them together and we combine them together, they have a great synergistic effect and they help with inflammation. They really just help with just get to those pain receptors. So my sample included strict inclusion and exclusion criteria. For the inclusion criteria, participants must be at least 18 years of age. Participants must have undergone a cesarean delivery via EHR or electronic health record documentation between September 1st, 2022 and August 31st, 2023. Deliveries must be applied first between September 1st, 2022 and August 31st, 2023, and only patients on a high-risk OB/GYN unit where the research will be conducted at the approved organization were allowed to participate in the study. The EHR has documentation in the medication administration record, also known as the MAR, of whether Tylenol and Motrin were administered every 6 hours following cesarean delivery. Proper documentation in the flow sheet of the EHR on whether Tylenol and Motrin aided in pain relief using a 0 to 10 pain scale. And this is the global pain scale where 0 is no pain and 10 is the worst pain you ever had. And proper documentation in the EHR postpartum flow sheet of pain location, clinical progression, pain score, tolerance, and pain intervention. And I would like to also point out that nurses should be documenting every single time they give a patient any kind of medication, whether it's Tylenol, Motrin, oxycodone, tramadol. They have to document that. And they have up to an hour to reassess their pain. So if the patient's pain score at 1900 was, let's say, a 6 out of 10 within an hour, so at 2000, we need to have that pain reassessed. So if it was not reassessed within that hour, then we kind of come into some trouble. Like we have to figure out whether they really assessed them. If they did reassess them, they didn't chart it. But if it was not charted, I didn't include it. And lastly, the EHR has documentation of opioid narcotic usage, hydrocodone, oxycodone, or tramadol as examples. And again, this was important as well because if I look through their pain management in the flow sheet and I noticed that their pain was, I don't know, let's say it was a 4 out of 10. I want to know whether they received a narcotic or not. Or if it was a 7 out of 10, did they receive a narcotic or not? And if they did, I need to know whether they received Tylenol and Motrin first. So for the exclusion criteria, these are the criteria that I could not, unfortunately, include in my study. And the first one is patients younger than 18 years of age because of legal reasons. It would have took a lot of paperwork to include these. We did have several patients who were under 18, but I did not include them in this study. Patients that had vaginal deliveries, of course, this is paying homage to the ERAS protocol, and a part of the ERAS protocol is surgery. So we did not include vaginal deliveries because they have their own pain management protocol, and also because it is not considered a surgery. Patients with a contraindication of Tylenol and Motrin. So, for example, patients who have liver disorders, bleeding conditions, allergies to Tylenol or NSAIDs. And it makes sense that we didn't use these, right? Because if they do have any of these contraindications, of course they wouldn't be using Tylenol and Motrin. So, also patients who receive hysterectomies after cesarean delivery, also known as CHIS. Again, I didn't use those because their pain is different. Not only did they have a C-section, but they also had a hysterectomy. So we did not include that. Patients who had intrauterine fetal demise or stillborns, and patients who were not admitted to the high-risk OB/GYN unit. So later on, I will discuss how this was a limitation to my research. Data analysis. So for data analysis, the following criteria was examined and used, which was descriptive statistics, quantitative methods, which were those pain scores at 24 hours postpartum for minimum and maximum dosages of Tylenol and Motrin. And lastly, the statistical package for social sciences, also known as SPSS, was used. So the portion of this project was analyzed to gather the data of a retrospective research that addressed pain management and cesarean deliveries by adhering to their early recovery after surgery protocol. So again, we used that global pain score and also received help from Dr. Mark Powles, which is the statistician at Maryville University. And he helped put everything together and make all this data make sense, which I greatly appreciate. Results. So for the results, I used the Mann-Whitley U test, and the Mann-Whitley U test is great It is a non-parametric alternative to the independent sample t-test. It is a non-parametric test that is used to compare two sample means that come from the same population and is used to test whether two sample means are equal or not. So it's useful for skew outcome distributions or small sample sizes like mine, and I compared pain scores between two groups, which were the minimal dosages and the maximum dosages. And for minimal dosages, the N equaled 44, the range was 0 to 2.54, and the mean rank was 2.54. And for maximum dosages, the N equals 36, the range was 0 through 1.62, and the mean rank was 1.62. So both groups had a sum of ranks totaling 0. However, this analysis indicates differences in the pain scores between the two groups, which is the patients who receive the minimal dosage and the patients who receive the maximum dosages. So the results for the Mann-Whitley-U test was a p-value less than 0.001, which is less than the level of significance of 0.05. So there was a statistical significance between the two groups in the study, which is amazing, and this is what we wanted to see. Here displays the data in two histograms. The histogram to the left shows the minimal dosages, and as you can see, it's kind of an ununiform distribution. However, the maximum dosages shows a more uniform distribution where it is skewed right. Again, as you can see, the mean for the minimum dosages was 4.34, and then the maximum dosage was 1.92. Limitations. The limitations. There were many limitations, unfortunately, but expected for this research study. One was single unit data reliance, which can introduce selection bias. So, as I mentioned, I only use my data from the unit that I work on, and I did not use data from the postpartum unit. I did this for convenience. It was easier to collect data from the unit that I was already working on versus another unit where it would have been a little more difficult. Also, it was a retrospective method that can cause inaccuracies in missing data, which I definitely ran across. When I was examining the pain scores from 2022 and I'm just examining and going through the charts, I noticed that a lot of the time nurses were not documenting their pain, patients' pain within an hour. So if they didn't document it, unfortunately, I couldn't use it for my data because I don't know whether their pain improved or not. So this was definitely difficult and unfortunate because I think if there was better documentation, I probably would have had a larger sample size, which leads me to my final bullet point. Small sample size limits statistical power and control over variables. So I only used 80 patients, and I don't think it's horrible, but I do have some recommendations for future research, and I wanted to start with first conducting multi-center studies with larger samples, okay? I also want to use prospective designs, and I want to include broader outcome measures for comprehensive analysis. So I do want to address these limitations that can enhance validity and applicability for findings, and I do want to improve pain management practices in cesarean deliveries rather. Discussion. So, as we know, there is support for scheduled regimens like the ERAS protocol for improving postpartum pain and cesarean deliveries. And we know that using the usage of non-opioids like Tylenol and Motrin immediately post-delivery decreased breakthrough pain, as I mentioned, and opioid use. So we know that postpartum pain within the first 24 hours, patients who received the maximum dosages of Tylenol and Motrin reported a mean pain score of 1 out of 10, and patients who received the minimum dosage reported a mean pain score of 4 out of 10. And to me, we know that yes, pain is subjective. Pain is whatever the patient says it is, but numbers don't lie. If 1 is clearly lower than 4. So I would rather have a 1 out of 10 pain versus a 4 out of 10 pain. So this project was supported by various studies indicating a standardized method improves post-operative pain management. And the ERAS has protocol benefits, such as it's a multimodal approach to pain management. It promotes maternal satisfaction, as we can see with the pain scores. It reduces opioid use. It accelerates recovery, which is nice because the quicker they get better, the quicker they can go home and they can bond with their newborn. And it improves, like I said, bonding with their newborn. So this is nice and it's great to see. And hopefully we can continue this approach with using the ERAS protocol or protocols that are similar. And what I have seen is mothers are a lot concerned. They're way more concerned with taking an opioid or a narcotic versus taking something that they can get at Walgreens or CVS. And a lot of the time in my own line of work, working on the high risk OB/GYN units, patients would say, does Norco cross the breast milk, or does Tramadol cross the breast milk? And they're concerned that if they do take it, they will become super sleepy and they will not have enough time to bond with their newborn. So it's really nice to educate them on this established protocol that we already have. And then also encourage them that if they need to take a narcotic, it's okay. However, we want to start with what we already have in place. Implications for practice. So again, we want to improve pain management by using the ERAS protocol, which can lead to more effective pain control strategies. We want to enhance recovery, which is effective pain management that facilitates faster post-surgery recovery. We want to reduce opioid use, such as using those scheduled medications that may decrease reliance on opioids. And we also want to increase patient satisfaction because we care about what our patients think. So better pain management and fewer side effects can lead to higher satisfaction levels and standardized approach. Again, the ERAS protocol provides a consistent evidence-based keyword pain management strategy. And lastly, it's a multidisciplinary collaboration amongst the doctors, the nurses, the residents to optimize pain management outcomes. So in conclusion, there was statistical evidence supported using a scheduled regimen of Tylenol and Motrin after C-sections to improve pain scores, and the ERAS protocol effectively reduces breakthrough pain and opioid use. It also improves maternal satisfaction, and lastly, it emphasizes ongoing research and practice improvements to optimize pain management and cesarean deliveries and enhance patient care. These are my references. Please, 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 if you have any questions, feel free to ask. Thank you so much for listening to my presentation and have a great day.